Richard Lipton. I'm a neurologist, epidemiologist. I'm a professor in both of those fields at the Albert Einstein College of Medicine in the Bronx, where I also direct the Montefiore Headache Center. So migraine overall affects about 18% of American women and 6% of American men, which makes it by far the most common neurologic disorder. The second most common disorder is epilepsy, which affects only 1% of the population. Migraine is more common in women than men, with a threefold increased risk in women. Migraine is most common between the ages of 18 and 55, which are the peak productive years, which is part of the reason why migraine has such an enormous economic burden by disrupting education and work life. So in terms of direct cost, better treatment is all about finding the highest value treatments that make it most efficient to release headache-related disability. Indirect cost is all about relieving pain and restoring people's ability to function, or helping them manage their headache attacks if they take place. And that combats indirect cost by taking people who are temporarily disabled and helping them function better. In addition to the pain of migraine, many people experience sensitivity to light, sound, smells, and movement. And as a consequence of that, people with migraine during attacks are most comfortable in a dark, quiet room. But obviously in a dark, quiet room, it's hard to function in the world, in the workplace, to take care of your family, to see friends, to go to a crowded restaurant, whatever. And then part of the burden of migraine is really the stigma. And part of that stigma arises from the fact that migraine has a very broad spectrum. So there are people with severe disease, there are people with mild disease, and oftentimes the people with mild disease, instead of feeling fortunate, feel that they're strong and they tough it out, and the people with more severe disease give in to their illness. One is developing improved treatments, which can be acute treatment, preventive treatments, or non-pharmacologic treatments. And research in all of those areas is part of what I do. And then the other issue is measuring the economic burden of better treatment, because access to care and cost effectiveness have become increasingly important issues. And unless you can demonstrate the treatment is cost effective, it might not be reimbursed. So economic burden is important both for understanding the condition, but also for determining who can be treated in the most cost effective way and taking those arguments to payers. Early in my career, I was very struck by the fact that migraine is really a disabling condition. So the word disability is loaded, and when you say migraine is disabling, sometimes that conjures images of people in wheelchairs. And of course, the nature of migraine disability for most people is temporary. Most people with migraine are able to return to relatively normal function between attacks. But there is a group of people who have what's called chronic migraine, where attacks occur on more days than not. The migraine headache becomes a pervasive disorder that touches every aspect of their lives. And so for me, measuring the burden of migraine and then finding ways clinically to relieve that burden and help people get their lives back is, something I find infinitely fascinating and gratifying. The most obvious manifestation of migraine is the attack, the onset of pain, nausea, sensitivity to light and sound that often produces temporary disability. But even between attacks, migraine has chronic effects, both at the biological level and the social level. People with migraine may live with the what if question. What if I get an attack today and I can't do what I need to do? What if I get an attack today and my boss doesn't understand? What if I get an attack today and my child is ill and needs me? And that what if question amplifies the burden of migraine so that the burden occurs not just on days when people experience headache, but on other days as well.